Hello, I'm Ryan McCormack from NYU School of Medicine. Today, on behalf of a large team that I'm honored to lead, I am presenting feasibility and impact of implementing buprenorphine initiation programs in 3 heterogeneous rural and urban EDs. We have no disclosures, and the study is funded by NIDA, specifically the Clinical Trials Network through the Greater New York Node. I also received funding through the EMF Foundation. CTN79 or ED Connect was a 3-site implementation study to evaluate the feasibility, acceptability, and impact of introducing ED-initiated buprenorphine in rural and urban settings with high need, limited resources, and different staffing structures. The study, its funding mechanism, and accelerated timeline originated out of an urgent need to learn about whether ED-initiated buprenorphine and referral is generalizable, as well as to develop strategies to facilitate its adoption across a variety of ED settings under real-world conditions. It was first demonstrated to be efficacious by the group at Yale through their landmark study led by Gail D'Onofrio and David Fiellin and published in JAMA. Our primary outcome is a measure of implementation. Specifically, it looked at the proportion receiving BUP among those who are willing and eligible to receive it in the ED. Our main secondary outcome focuses on effectiveness. It looks at the proportion engaged in addiction treatment on day 30, which is the primary outcome for the Yale study and several ongoing pending studies. Both our study complements and uses methods adapted from another NIDA implementation effectiveness trial, which uses implementation, which I'll refer to as IF, to integrate ED-initiated BUP and referral programs, and it focuses in large urban academic centers. Our study, on the other hand, takes place in 3 clinical sites that are specifically chosen for having unique challenges to implementation, so to inform a range of implementation strategies for broad generalization. These include Catholic Medical Center, which is an urban community hospital with contracted providers in Manchester, New Hampshire. Valley Regional is a rural critical access hospital in Claremont, New Hampshire, and Bellevue Hospital is a large public safety net hospital in New York City that is understaffed relative to most EDs. We used a multifaceted approach to develop and iteratively refine site-specific clinical protocols and implementation plans, from opioid screening, BUP initiation, and for screening, treatment, and referral. We evaluated feasibility, acceptability, and impact. Although I'm focusing on the quantitative data today, we used mixed methods incorporating data derived from abstraction of medical records, administrative data, assessments of recruited patient participants, as well as surveys and qualitative inquiry involving key informants from the emergency department and clinical staff, patients, and other stakeholders. Our implementation strategy used an adapted IF procedure and participatory action research approach, which entailed rapid cycles of gathering information, planning, implementation, and assessment. The study external facilitators, namely Kate Hawk and me, conducted the formative evaluation with the aforementioned key informants, identified and worked with local champions, performed the academic detailing on site, and led weekly conference calls. Upon receipt of IOB approval, we made the initial site visits, then conducted pre-implementation assessments, developed the protocols and implementation strategies, and these were introduced and refined throughout the study. Once the hospitals approved the clinical protocols, began a 6-month period of evaluating each program through EMR abstraction as well as the patient enrollment. Thereafter, we've repeated focus groups and qualitative interviews. The clinical protocol was implemented by clinical staff, not as a research procedure, such that the ED staff performed all of the clinical actions from screening to treatment and referral. Treatment thereafter was assumed by the next outpatient provider to whom the patient was referred, as this would occur naturally. The research team only stepped in once all opioid-related care in the ED was completed. This typically occurred after the ED visit, and did so in order to enroll a purposive sample of patients for baseline and 30-day assessments. We designed recruitment this way, importantly, to not influence or interfere with care as we're trying to learn about implementation. So our primary outcome data of receipt of BUP was abstracted from the EMR without participant enrollment. It was the subgroup of these patients who were then enrolled to become participants for the secondary 30-day patient level outcomes shown in this slide. We did include a small number of participants who did not receive BUP in order to learn about processes, barriers, and facilitators better. And before talking about the results, I just want to summarize some of our efforts. We received about 150 pre and post surveys. We held qualitative interviews and focus groups with about 45 participants, both before and after. Kate and I made 5 site visits to each site for academic detailings, meetings with stakeholders, and held 24 learning collaborative calls, as well as other meetings and feedback throughout. All sites successfully implemented programs, and in order to do this, all of this under an accelerated timeline required much more effort than was anticipated, as we learned that there really weren't many resources that were ED specific available at the time. So on to our results. 134 unique patients were identified to be candidates to receive ED-initiated BUP, and about 84% actually received it. This exceeded our expectations, and importantly, this was not done by a couple of providers. It was initiated by about 50 unique providers across the 3 sites, and there was high fidelity to the critical clinical actions. In terms of our effectiveness outcomes, we enrolled 46 participants, 40 of whom received buprenorphine. 96% completed all study visits. 70% of the participants reported seeing an addiction provider after their ED visit, and half were confirmed to be engaged in treatment on day 30. Non-medical or illicit opioid use decreased. This was measured both by self-report as well as urine toxicology, showing that about 51% had negative tox for illicit opioids. Overdoses decreased by, and this was statistically significant. The odds ratio of 4 indicates that in the month prior to the follow-up visits, participants were 4 times less likely to report an overdose event than in the month prior to enrollment. Buprenorphine use was confirmed by toxicology in 80% of the participants, and in terms of acceptability, scores were quite high. Despite the relatively small sample size, these results are extremely promising, particularly considering this is an extremely challenging patient population and that the ED itself is inherently challenging, both for research and clinical programmatic implementation, and particularly the site selected for the study. The duration of this presentation doesn't allow me time to describe the barriers encountered, and these would provide additional context into how remarkable these findings are and how they support the ongoing clinical implementation efforts and research, which includes a follow-up study to this one to look at the sustainability of these programs. And in this last slide, I just want to extend my gratitude to everyone who has helped with the study and for all of you for your attention, and leave you with some of the resources, including 2 recent publications and the websites and materials developed to support clinical implementation and research. Always feel free to contact any one of us. It's been a highly collaborative process. So thank you again.